Madeline McCrary, MD, is an assistant professor in the Division of Infectious Diseases at the Washington University School of Medicine in St. Louis. Her specialties include clinical infectious diseases, addiction medicine, and drug use related infections. She is the medical director of the Outpatient Parenteral Antimicrobial Therapy Program. Her focus areas are hepatitis C treatment, infectious disease intervention among pregnant people and people in rural areas, clinical care quality improvement, telehealth, program development, and substance use. Welcome, Madeline.
Yeah, so my name is Madeline McCrary. I'm an infectious diseases and addiction medicine physician at WashU in St. Louis, so in Missouri, and I'll be talking about our work on implementing shared decision making for Hep C treatment in pregnancy. My relevant disclosure has been mitigated. In 2022, the IDSA and AASLD updated their guidelines to endorse shared treatment in pregnancy through shared decision making. This is a screenshot of the guidelines, so it's not in a green box, but the statement is there, and there are no statements on treatment during breastfeeding. However, the American College of Obstetricians and Gynecologists recommendations diverge and currently do not support treatment during pregnancy or breastfeeding. Why not wait until postpartum? Well, this has been the default standard of care, and it's not working for parents and it's not working for babies. We looked at insurance claims data in the US from 2015 to 2019, and less than 1% of women with Hep C opioid use disorder and a past year pregnancy were prescribed Hep C treatment compared to 5% of women with no pregnancy and 7% of men. Similarly, poor treatment receipts among postpartum women with opioid use disorder were also reflected in a study on Medicaid data. Exposed babies are also not getting tested. For example, among deliveries affected by Hep C at our hospital from 2020 to 2023, only 21% of exposed infants were screened, with a 10% perinatal transmission rate. This is about what recent literature is showing, which is about 8%. Pediatric screening guidelines were changed recently, so hopefully that'll help, but we're likely only seeing the tip of the iceberg in terms of impacts on children. Effects to improve postpartum treatment include intensive co-location of OB, addiction, and Hep C services, engaging women in labor and delivery, and OB specialty pharmacy partnerships. And these do significantly improve receipt of Hep C medications to about 50%. But these are single center, often resource intensive programs, and it means that half of women are not getting access to medication postpartum. More often than not, I bet you these women are only being re-identified during their next pregnancy. And while these programs do great work and increase treatment access substantially, antenatal treatment might help us close the gap. And this is all such a shame because many pregnant patients want treatment in pregnancy, or at least the opportunity for an informed discussion of risks and benefits. One quote in the Ye et al. Paper that stood out to me was this: "One thing I wish would have happened somewhere along the way was that I would have been given treatment options." In 2024, we started offering patients Hep C treatment in pregnancy through shared decision making. Our goal is to proactively offer patients multiple time points to engage in Hep C care. Our team consists of 3 ID providers who treat Hep C in pregnancy, a maternal fetal medicine or OB champion, and a social worker and 2 nurse navigators who are amazing at rapid scheduling, following up on labs, and who also liaise with parents, guardians, and pediatricians to ensure exposed infant screening at 2 to 6 months of age. This program was approved as a health system-wide initiative. Our health system stretches across 2 states and performs over 11,000 deliveries per year. This system-level support allowed us to have electronic medical record report that identifies all women seen in the health system with open pregnancy episodes and active Hep C. We then proactively contact the obstetric provider to see if it's okay to reach out to the patient to offer an appointment. We'll see patients for an initial visit anytime in pregnancy, in person, in the hospital, or via telemedicine. This visit focuses on education and discussing the risks and benefits of each timing option. We then offer expedited postpartum treatment and treatment in pregnancy. If the person chooses postpartum treatment, we'll set them up for treatment, can bring meds to labor and delivery if they deliver at our main hospital, or ensure delivery of medications to the home just prior to or after birth. We also support women to breastfeed while taking hepatitis C medications. If the patient opts for antenatal treatment, we start medications in the 2nd or 3rd trimester. ideally after the anatomy scan, and this avoids organogenesis in the first trimester. And then we use the DAA, or direct-acting antiviral, preferred by insurance. Because of the short duration of treatment courses, you can cure someone's Hep C before they deliver, or at least substantially reduce the amount of virus in the blood prior to delivery. I do want to touch on breastfeeding while taking medications, as many providers defer treatment until after completion of breastfeeding because of a supposed lack of data, which may contribute to high loss to care. First, LactMed, a very nifty, handy website, states that the amount of medications in breast milk are expected to be extremely low. And second, there is some data to support the safety of DAAs during breastfeeding, and the papers are linked to the QR codes. So there's actual PK or breast milk concentration data on Softel or Epclusa that supports the safety of this medication. And then we also recently published a paper on delivering medications to labor and delivery with data on 23 patients who reported breastfeeding on DAAs, including 21 on Glipib or Mavorite, with no infant adverse events reported. On the other hand, among infants that were not exposed to DAAs and breast milk, there are 3 neonatal demises and 3 with liver enzyme abnormalities from vertical hepatitis C transmission. We do have a prospective study we're about to wrap up on Glipib concentrations in breast milk. So stay tuned for those results in the next several months if you think that might be helpful. But from our institution's perspective, there's no reason to not treat while breastfeeding. We treat infants once they reach 3 years old for Hep C anyways, and the amount getting into the breast milk is likely minimal. So the risk for harm is extraordinarily low. And we really question sort of what the harm we all conceptualize is. Moving on to how we approach Hep C treatment in pregnancy. Most pre-treatment labs are obtained during the usual pre-treatment workup. Sometimes there aren't liver enzymes to review, but we'll order them that visit. Since we don't start treatment until about 18 to 20 weeks, we usually have those labs back by then, or they're obtained for obstetric care anyways. We use a FIB4 and a patient history as a cirrhosis assessment, and then we obtain a prior treatment history. We treat using the agent preferred by insurance, which in Missouri is typically Glipib. And this simplified approach enables us to do visits by telemedicine and reach women across our health system. Of the people we were able to have shared decision-making conversations with, 54% were by telemedicine. The remainder were seen during OB visits in our integrated ID OB clinic or in the hospital. I do want to note that no patients actually came to our standalone infectious disease clinic. We tried having in-person visits initially, and that was like completely unsuccessful. We had to meet people where they were. And people are all over. So we're located in St. Louis, the Yellow Star, which is right on the border with Illinois. And telemedicine really allowed us to reach women in rural areas who otherwise have pretty limited access to Hep C treatment. Our discussions consist of 3 topics. First, Hep C education, including the need for exposed infant screening, treatment options, the pros and cons of each, and patient priorities. We discuss that there's adverse associations and effects of Hep C in pregnancy, namely cholestasis of pregnancy and vertical transmission. But for vertical transmission, this would just mean following baby. Many babies clear the infection, and if it doesn't, we use the same medications to cure baby once they're 3 years old. This is balanced by the limited safety data of DAAs in pregnancy. We discuss that there's no signals of harm or reasons to suspect harm, but we just don't know. I do want to note that there's I would say probably monthly new data coming out on this topic. And so it really is an evolving field in terms of the safety information on direct acting antivirals. We discussed that data right now is limited and that there are ongoing clinical trials, but most medications are not studied in pregnancy. So clinical trials in pregnancy are really not the norm. The norm is treating with registries to monitor for efficacy and for any adverse events. To mitigate this sort of lack of data, we start in the 2nd or 3rd trimester, and we get labs while on treatment, which we normally would not do. Postpartum treatment is safe, but carries the risk of just not happening. Patients then express what their priorities are. So far, patients seem to prioritize safety, the potential to reduce transmission risk. Even after discussing, we do not have studies designed or powered to explicitly prove this. But in the words of one patient, it just makes sense. Prior experiences with attempts to access treatment postpartum and having pregnancies affected by Hep C, or quote, just wanting to get it done. Over a period of 18 months, we identified 36 people with active Hep C in pregnancy. 75% of patients reported ongoing or past substance use. One third of patients had a prior pregnancy with known hepatitis C and were not subsequently treated. This is actually lower than our prior cohort where we delivered medications to labor and delivery. And that was at our local hospital. And in that cohort, 87% of women had prior pregnancies affected by Hep C without subsequent treatment. And so this really is a vicious cycle of screening routinely in pregnancy, which is wonderful, but then not treating. And so we really just identify these patients a lot of times in the next pregnancy because that's when people access healthcare. 83% of patients were referred to or contacted by ID, and we were able to have shared decision-making conversations with about 80% of contacted patients. 75% of patients chose antepartum treatment despite limited safety data. Of 18 patients who wanted treatment in pregnancy, one was unable to start due to insurance denial, and one patient received treatment but did not start. 16 patients started treatment between 18 and 30 weeks gestation. However, 3 patients self-discontinued within 1 week of treatment initiation. Of the 13 patients who continued treatment, 11 were treated with Gleep-Pib and 2 with soft bowel. All had undetectable viral loads at or by delivery. 6 infants have had exposed infant screening and all are negative. 11 patients have completed treatment. We have not been able to confirm treatment completion for 2 patients. 10 of the 11 patients have delivered and all were at term. SVR4 was obtained on 9 of 11 patients. We haven't been able to get labs on 2, and it has been difficult to get SVR12 labs, especially if they're postpartum at the time they are due. If patients did not have an appointment during pregnancy with us, there's very limited receipt of medications postpartum. There's also high loss of follow-up for those who engaged in shared decision-making and chose postpartum treatment. Some patients fall out of prenatal care, become unreachable, precluding medication coordination as it does require a specialty pharmacy. All patients who switched from antepartum to postpartum treatment had DAAs on hand or were prescribed DAAs at the time of delivery. Infant screening has been limited. Only 8 have been screened in our system so far, and there have been 2 known perinatal transmissions, which is about an 8 to 9% transmission rate. So you can do this in Oregon and with much more data than we can in Missouri. So Oregon Medicaid covers both Gleep-Pib and generic soft bowel, which has an ongoing clinical trial in pregnancy with a large number of patients already enrolled and impressive results so far. The Gleep-Pib clinical trial just started, so does not have interim data yet, but our institution does plan on publishing our real-world data soon. Based on the most recent interim data from the soft bowel clinical trial, which is linked to this QR code, and according to the leader of the study, providers and patients should have very little concern about using this medication in the 2nd or 3rd trimester of pregnancy. There have been no safety signals, no cases of cholestasis in pregnancy, which is associated with Hep C and has an increased risk of stillbirth, and no perinatal transmissions. Everyone so far has achieved cure. This does not seem to be, there does not seem to be any downside and may carry substantial benefits. If you do treat in pregnancy, we encourage you to submit your cases to the TIP Hep C registry. In conclusion, there are multiple opportunities to engage women in Hep C care during and after pregnancy. The antepartum period is when people are screened and diagnosed with Hep C, so it can be an ideal time to discuss timing of treatment based upon the patient's priorities and shared decision making. We can cure people during their pregnancy or at least reduce viremia by delivery or coordinate treatment in advance. This is also an opportunity to provide education on exposed infant screening. However, some patients may not engage with the healthcare system until delivery. Admissions to labor and delivery are also touch points to set patients up with treatment. Lastly, postpartum treatment is still an option, and at WashU, we support women on Hep C medications to breastfeed. However, even after engaging in shared decision-making conversations, many patients who chose postpartum treatment were lost to care prior to and after delivery. By providing patients with options and the opportunity to choose what is right for them, we hope to improve access to medication and prevent further Hep C transmission. Thank you. I can take any questions if anybody has any.
Any questions from the room on this?
So is it possible for baby to get pregnant or something? Like just from being in the womb, not from delivery? Great question.
Yeah, so we aren't exactly sure exactly when transmission happens, but it's thought to occur later in the second trimester and third trimester, and then at delivery. And so, yes, it is possible to get hepatitis C actually during pregnancy, and not just at the time of delivery.
You have a question online. Hey y'all, we have a question in the chat from Shannon O'Brien. Wondering if the hospital engagement piece pie chart earlier in presentation, were those individuals in hospital for delivery or something else?
Yeah, so those were patients who were admitted to our, so they were people who were not admitted for deliveries. They were people admitted for things like either complications in pregnancy, or most often it's people admitted to get onto medications for opioid use disorders. They come in with withdrawal and then started on buprenorphine or methadone. And so we would see them while they were in the hospital then. But we would also see people at, this wasn't included in our care cascade, but we had a prior program where if people just show up to labor and delivery, we would see them then to get the medications at the time they deliver.
Thank you, Madeline. Any other questions?
Madeline, what's the biggest fear women have to going through treatment or even getting tested for Hep C when they're pregnant?
So I'm not sure about the screening part, just because that happens before I see folks. But I think, when I talk to patients, either people have concerns about safety, in which case they defer treatment. And this is all anecdotal right now. We've noticed that a lot of times in those situations, people also tend to have a lot of other competing priorities. But the biggest thing that people want and are fearful of is like, they want to do anything they can to reduce the risk of transmission to baby. And we can't say for certain that treatment, especially as later on in pregnancy, would actually eliminate that risk, but people still want to do anything they can to like do what they can for the health of the pregnancy and the health of the baby. And so that's really, I think there's a lot of I don't know, fear that comes with that their infant would get Hep C, even though like we explained that this isn't HIV, for example. Like we have a cure for infants too, and a lot of them go on to clear the virus by themselves by the time they turn 3. But people want to do whatever they can to prevent that. And we want to respect that and offer them that choice.
Well, thank you, Madeline, for all your great work. Thank the team for everything you're doing, and keep it up. Together we can eliminate hepatitis.
Yeah, thank you so much for having me. I do know that folks at OHSU are offering treatment in pregnancy. I think they could speak more to that. But if anyone has any questions, please send me an email.
Which is awesome news that we can refer people here to treatment. That's great. Thank you.